in this video, let us start the second part of ruptured ectopic pregnancy, and we'll end this lecture by this. So what is the role of contraceptive agents in ectopic pregnancy? Now let us see. Actually, the contraceptive agents decrease absolute risk of ectopic pregnancy. Even though they decrease the risk of ectopic pregnancy, overall chance of any type of pregnancy, not only ectopic, normally contraceptives, what they do is they decrease the chance of any type of pregnancy. But when they fail, what happens? It will lead to increased chance of not normal pregnancy but the ectopic pregnancy. This is very important. When the contraceptive fails, there is higher chance of ectopic pregnancy. And in that contraceptive method also, what is the most common one? Let us see in order. Tubectomy have the most common chance, followed by IUCD, followed by POP, that is progesterone only pills. Okay, and especially in IUCD, if you see the order of there's higher chances of ectopic pregnancy is done by using progestasert greater than Mirena greater than calcium IUCD. So these are the instruments which may lead higher chance of ectopic pregnancy, and least chance of ectopic pregnancy is seen in OCP and with vasectomy failure. So these things we need to understand regarding contraceptives related with ectopic pregnancy. Now let us go into the main part, like what are the symptoms of ectopic pregnancy. So coming to the symptoms of ectopic pregnancy, the most consistent symptom of ectopic pregnancy is pain in abdomen. So if any female comes to you with severe pain in abdomen, which is you should suspect about ectopic pregnancy. This ectopic pregnancy is in turn divided into ruptured and unruptured. So what is this ruptured and unruptured? Let us understand. Ruptured ectopic pregnancy will lead to hemopericardium. Hemoperitoneum. Peritoneum is nearby, right? So the blood will fill in the peritoneum gap, peritoneum fluid, right? And it will irritate the diaphragm. And this will lead to shoulder tip pain. So if anyone is associated with abdominal pain and shoulder tip pain, then you can suspect this. And this sign is also called as Danforth sign. Okay. And next, coming to unruptured ectopic pregnancy, here actually there is stretching of fallopian tube, and there is a triad of symptoms which you see here, that is amenorrhea, bleeding, PYB, and pain in abdomen. So these are triad which you see in unruptured ectopic pregnancy. So in 50% cases you will see this triad. Two reactions are brought up by progesterone, especially during pregnancy. That is a decidual reaction and area-stellar reaction. We know about this already, right? Progesterone will lead to decidual reaction and areas stellar reaction. The decidual reaction is seen in intrauterine and ectopic pregnancy. Area stellar reaction, it's where you see enlarged endometrium and epident cytoplasm, and important thing is you see hobnail nucleus. Okay, and it is seen in intrauterine, ectopic, molar, everywhere you see. But in the case of decidual reaction, you see it only in intrauterine and ectopic. But here you also had molar pregnancy. Okay, so everything is seen in this area stellar reaction. So now let us see in patients of ectopic pregnancy what are the changes they are having. In the patients of ectopic pregnancy, okay, patients of ectopic pregnancy, progesterone is present in less amount, so they have low progesterone. So the decidua shed in the form of a decidual cast, so it will be like some blood cast. Okay, and it is made up of decidua vera. So there is a patient coming to you and saying there is a decidual cast, then you can confirm it as ectopic pregnancy. And what are the signs of this decidual cast is cervical motion tenderness. You'll have decidual cast, cervical motion tenderness. In differential diagnosis, you will see pelvic infection, and you will see presence of adnaxal mass is present. Okay, now coming to diagnosis and management of ruptured ectopic pregnancy. So diagnosis is clinical diagnosis. You will see complaints of amenorrhea, that is like about 6 to 10 weeks. You will see pain in abdomen, and you see there will be shock and bleeding. You will see bleeding, PYB. So all these are shown especially in patients with UPT positivity and pregnancy test positive, and this is confirmed as a ruptured ectopic pregnancy. So in ruptured ectopic pregnancy, you will see 6 to 10 weeks of amenorrhea, pain in abdomen, and sometimes shock may be present or not, but bleeding is present. This is a critical case of ruptured ectopic pregnancy. So the management is nothing but you will do surgery of choice, that is ruptured ectopic. You will remove the tube which is damaged, and next you will do the salpingectomy. So what is this? Whether the female is nulliparous or multiparous, salpingectomy will just remove the fallopian tube, but you will not remove the ovary. Okay, that is important. So following are not done in ruptured ectopic, that is medical management is of no use because we need to do surgery immediately. And expectant management, like we should not expect for any other management, just go and do this surgery. And next, any other surgery except spalingectomy. So only we need to do spalingectomy. Keep it a big, give it a big box like this. Very important procedure needed in ruptured type of ectopic pregnancy. Remember that we should never do salpingo-oophorectomy, because this is a ectopic pregnancy is seen actually either in a young nulliparous or multiparous woman, like already she may have one kid or sometimes she may not have, but we should do only spalingectomy, only remove fallopian tube. Never do oophorectomy means never remove ovary in this patient, because the tubes are removed in ruptured ectopic, ovaries are still retained. Because if you remove ovaries, there is like menopause like symptoms in such a young female. Okay, so don't do this, only do salpingectomy, never do salpingo-oophorectomy. Okay, it should be never done. Now coming to culdocentesis. So what is this? Culdocentesis is where a needle is passed, for example, think is needle is passed via posterior fornix, okay, posterior fornix, and non-clotting blood. If you pushes to posterior fornix, or non-clotting blood, if the non-clotting blood is coming, then it is a sign of hemoperitoneum, and you know there will be hemoperitoneum in the case of ruptured ectopic pregnancy. But if the blood is clotting, the blood which comes out is clotting, then it is a needle which is pierced in artery. So this is a mistake, you should not pierce it in artery. But sometimes if the blood is coming and it is clotting, then that blood is coming from artery, but the hemoperitoneum blood will not clot. Okay, so by this you can confirm whether it's ruptured ectopic pregnancy or not. So but one more thing you need to remember, that culdocentesis will not confirm ruptured ectopic pregnancy. Just we are doing this for our understanding that yes, there is presence of hemoperitoneum, but remember that it is not a criteria to confirm the ectopic pregnancy, ruptured ectopic pregnancy. So by this we completed ruptured ectopic pregnancy. Next we will start our lesson on unruptured ectopic pregnancy and salpingectomy in another video.